Thank you, Dr. Najmul Islam, for such a wonderful talk. Our second speaker is Dr. Kamran Saeed. He's a consultant radiation oncologist at JPMC Karachi, and he is going to talk about targeted radiosurgery for pituitary tumors, personalized approach for optimal outcomes.
Bismillahirrahmanirrahim. Assalamu alaikum. This is our department of cyberknife and tomotherapy. It is in Jinnah Hospital, Karachi, and it is being run by Patients Aid Foundation, which is an NGO. This was our first cyberknife. It was a refurbished G4 model, and it became operational in 2012. Till this year, when its parts were not available, it was dismantled. With this technology, we delivered more than 14,000 fractions of radiosurgery. In its place, Alhamdulillah, now we are installing latest brand new S7 cyberknife. For the knowledge of my audience, I briefly will go through how cyberknife works. This part over here is a linear accelerator. It produces 6 MV X-rays. It's of same energy available in every cancer hospital of Pakistan. But the major difference is in all other cancer hospitals, it is mounted on a gantry and it only has 360 degrees of rotation available. But in CyberKnife, it is attached to a KUKA robot, which provide more than 1400 angles to the linear accelerator to aim its target. Sorry. The other cutting-edge technology of CyberKnife is real-time image guidance system, which is not present in any other radiotherapy machine in the world. By this, we can track tumor during entire treatment time. This is being done by 2 roof-mounted X-ray units, and on the floor there are concealed image detectors. After every precise time, images are being taken and they are fused with the baseline images, and if there is any movement of the tumor, it is corrected by the robot. The apparatus over here is called as synchrony. With the help of this part, we can treat tumors that move with respiration. So we can treat tumors of the lung, liver, pancreas, and kidney with very high ablative dose of CyberKnife. Sorry. This is our second CyberKnife. It was functional in 2012. Daily we treat 10 patients with this CyberKnife, and we have delivered more than 4,600 fractions with this CyberKnife. For the treatment of CyberKnife, patients came from 167 cities from all over Pakistan and from 15 countries worldwide. For the treatment of radiosurgery, patient representation, majority of patients belong to province Sindh, followed by Punjab, then KPK and FATA, and Balochistan. And 4% of our patients came from 15 countries worldwide. Apart from radiosurgery facility, we also provide conventional radiotherapy facility. This is our latest tomotherapy machine, and it is the only tomotherapy machine available at our center. This became functional in 2020, and it has delivered more than 15,000 fractions. We also have a Cobalt-60 unit. It became functional in 2017, and it has delivered more than 51,000 fractions. And this is our PET-CT facility at our center. If you go to any state-of-the-art cancer hospital, the planning and simulation costs 1 to 2 lakh rupees. And the treatment of radiation treatment vary from 4 lakhs and goes up to 11 lakh rupees. The investigation done by PET-CT costs from 80,000 and goes up to 1.5 lakh. But at our center, there is no charge for any facility which we provide. We do not have any cash counter at our center. Every treatment, every facility, it is totally charge-free. Now coming to the main topic, the treatment of pituitary adenoma, basically it needs a multimodality team comprises of endocrinologist, neurosurgeon, and radiation oncologist. Being a radiation oncologist, I will only focus in the field of radiation oncology. In the beginning, patients were treated with two-dimensional radiation. Basically, it was two parallel opposing portals in which pituitary adenoma was targeted. But the drawback was that the temporal lobe received very high dose of radiation, and these patients often developed temporal lobe necrosis. With the advancement of time, two-dimensional was replaced by three-dimensional radiation, and instead of beam-directed radiotherapy, patients were treated by 5 or up to 8 directed beams. And now patients are being treated with IMRT. With technological advancement, dose delivery is more conformal, but dose escalation was not possible with all these technologies. If you review the literature about conventional radiation, control rates are approximately 80 to 95%, but it requires a very long follow-up of 10 years. Biochemical emission was only 40%, but it also requires a time period of 4 years. And with conventional radiation, there is a high risk of hypopituitism. Now coming to cyberknife radiosurgery, as I've told you before, that the patients are being targeted by more than 1400 beams, and this pituitary adenoma, they are being treated by hundreds of beams. Each beam carry very minute amount of radiation, and when it passes through the brain, it does not do any harm. And all of these beams then focus on our target, that is a pituitary adenoma, and thus giving very high dose of radiation, not possible with conventional radiation. The beauty of radiosurgery is a rapid dose fall-off. That is, that the adjoining critical structure receive very low dose of radiation and thus cause least toxicity. In this MRI, which is actually our treated case, you can clearly see that the pituitary chiasm is being compressed by the tumor, and the posterior brainstem is also compressed. People often ask me, what is the safe distance between the optic chiasm and the tumor? And I say to them that if I can visualize and draw the optic chiasm on our planning system, then the distance does not matter. Radiosurgery is being done in 1, 3, and 5 fractions. It depends upon different factors, but in case of pituitary adenoma, the most important factor is the optic chiasm. In this MRI, you can clearly see the safe distance of the optic chiasm from the tumor, and this tumor can easily be treated with a 1 fraction radiosurgery. On the other hand, it is a large tumor with optic chiasm closely abutting the tumor. So we have treated this patient with 5 fraction of radiosurgery. Why we prefer radiosurgery over IMRT? Radiobiologically, pituitary adenoma has a low alpha-beta ratio, about 2 gray. A low alpha-beta value indicates a tumor that is very sensitive to high radiation dose as delivered in 1 to 5 fraction of radiosurgery, resulting in better radiological and excess hormone control compared to conventional radiation. This is SRS algorithm for non-secretory type. If it is a microadenoma, there is no role of upfront or any active treatment. These patients should be referred to endocrinologist, and they should be serially monitored by the MRI. But if it is a macroadenoma and causing compression of the critical structure, then surgery is the first option, which is a gold standard. And if surgery fails to control, to remove the whole bulk, or there is progression in the future, then radiosurgery is the second option. For functional pituitary adenomas, first of all, a prolactinoma, there is no role of upfront surgery or radiosurgery in these patients. These patients are managed by anti-secretory medications, and if anti-secretory medications fail to control excess hormone or patient becomes refractory, then surgery is the gold standard. And again, if surgery fails to control excess hormone, then radiosurgery is the third option. For acromegaly and Cushing disease, surgery is a gold standard, and if surgery fails to control excess hormone secretion, then radiosurgery is the second best option. Second best option. This is a clinical scenario of a patient with a pituitary adenoma. The pointer is not working. This is a patient of a pituitary adenoma, and you can see that the optic chiasm is far away far away from the optic chiasm is far away from the bulk of the tumor, but on the same time, it is invading the right cavernous sinus. So one might think that why not offer this patient upfront radiosurgery, and why to send a patient for surgery and then go for radiosurgery? This option might be okay for non-functional pituitary adenoma, but for functional pituitary adenoma, this is not justified, as just told by Professor Najmul Islam Saab. I will tell you why. This paper was published in Journal of Neurosurgery, and it is about factors related to radiological endocrine outcomes. And according to authors, patients with lower adenoma volume achieve early remission with radiosurgery compared to large residual tumors. Thus, for functional adenomas, maximum surgical debulking should be the standard of care before these patients are referred for radiosurgery. Now, something little bit about anti-secretory medications. If these anti-secretory medications are used with conventional radiation or SRS, they will lead to SRS control from 87% to 16%. How these medications affect SRS? They either decrease cell division or they act as a radiation protectors. At our center, we have a policy to stop these medications 6 to 8 weeks prior SRS. And after SRS, patients are referred to endocrinologist. Under their guidance, they receive these medications for 6 months, followed by 2 months of drug holiday, and then check hormonal levels. This practice should continue till normalization of excess hormone is achieved. Management consideration depends upon patient's age, comorbidities, hormonal status, response to medical management, especially in prolactinomas, volume of tumor, spread to cavernous sinus, and compression of the optic apparatus, previous surgeries. Prior radiation exposure is contraindication of re-radiation due to low tolerance of optic chiasm. Once a patient has received radiation, either through conventional radiation or by radiosurgery, there is no room for re-radiation in those patients due to low tolerance of the optic chiasm. Now, coming to review of literature about non-functioning pituitary adenoma. Microsurgery control rates varies from 50 to 80%, but these rates decrease with the involvement of dura or cavernous sinus. Conventional radiation, as I just mentioned, has a control rate of up to 95%, but it requires a very long time. And it's also carry a high risk of hypopituitarism. Radiosurgery control rate varies from 80 to 100%, and previous radiation is a contraindication. Regarding Cushing disease, microsurgical remission rate varies from 70 to 98%. On the other hand, radiosurgery remission varies from 17 to 87%, with the average of about 50%. Endocrine remission is typically achieved 12 months after SRS, but it may go beyond it, and it may take 3 to 5 years. For acromegaly, surgical cure rate varies from 50 to 80%, but with radiosurgery, its control rate varies from 0 to 80% with average of 45%. Mean time to endocrine remission after radiosurgery is 24 months, which is twice as long as for Cushing disease. For prolactinoma, medical management is the standard of care, and biochemical remission with anti-secretory medication range from 0 to 83%. Surgery is indicated for medically refractory, intolerant to these anti-secretory medications, and those who suffer from pituitary apoplexy. Radiosurgery is indicated in refractory prolactinomas and has a control rate range of 0 to 83% with the average of 30%. Its control rate is lower than Cushing and acromegaly. In radiosurgery, tumor morphology does not matter, whether it is a microadenoma, macroadenoma, cellular extension, or cavernous sinus. Tumor control is in the range of 96 to 100%. Now, lastly, coming to adverse effect of radiosurgery, the most important is the hypopituitarism. The onset of hypopituitarism is delayed, and it often takes more than 2 years. And the hormones most affected are growth hormones, testosterone, TSH, and cortisol. Radiation dose to the pituitary stalk is the most important factor for its adverse effect in pituitary adenomas. Other side effect, Dr. Najmul Islam just mentioned: damage to cranial nerves in the cavernous sinus, radiation necrosis, internal carotid artery stenosis, and lastly, radiation-induced secondary malignancy. It is very rare, but it is not zero. Now, lastly, coming to our 11 experience of treating pituitary adenomas. We have treated almost 458 cases, 58% belong to non-functional group, and 42 were functional. Among functional, 84% were acromegaly, 12% Cushing disease, and 4% were refractory prolactinomas. Regarding our result for treating non-functional pituitary adenomas, total patients were 263. Majority were males and age range from 17 to 79 years. 89% of our treated cases has undergone surgery before SRS, and 44% had some form of hormone deficiency before SRS. 84% of our treated patients had their abnormal perimetry before SRS, and unfortunately 4% of our patients were totally blind before SRS. Perimetry result after SRS, 78% of perimetry results improved, and 20% remained stable, and 2% got deteriorated after SRS. These are the images of the perimetry. On the left are the perimetry images of the pre-SRS. On the right are the post-SRS showing improvement in their vision. Regarding radiological response of treating non-functional pituitary adenoma, 4% of our treated cases showed complete resolution, 78% showed reduction in the tumor volume, and 17% remained stable, making 99% tumor control. There was only progression in one case which we treated during 11 years. And post-SRS pituitary hyperfunction was seen in 10% of our treated cases. Now coming to results of our acromegaly cases, total patients were 160, majority were males, age range from 16 years to 68. 87% of our patients underwent surgery before SRS, and 29% of patients had some form of pituitary deficiency before SRS. 59% of our treated cases has perimetry affected before SRS, and perimetry done after SRS showed that 75% showed improvement, and it was stable in 22%. 3% of our patients' perimetry deteriorated after SRS. 5.5% of our treated cases of acromegaly showed post-SRS pituitary hyperfunction. Regarding radiological response to acromegaly cases, 7% showed complete resolution, 77% were reduced, and 16% were stable, making 100% tumor control in our acromegaly cases. There was no progression seen in our treated cases. Regarding biochemical response, 34% achieved normalization of their excess hormone, and 57% are controlled or reduced and are as they are in their latency period. 9% of our treated cases, in them, there was no control of excess hormone beyond the latency period. Now coming to our results regarding treatment of Cushing disease, total patients are 23, majority are females, age range from 8 to 70 years. 65% of our treated cases had surgery before SRS, and 48% had some form of pituitary deficiency before SRS. Regarding perimetry, 61% has deranged perimetry before SRS, and unfortunately 4% of our treated cases were totally blind before SRS. And perimetry result after SRS, 62% showed improvement, and 25% had a stable perimetry results. 12% cases showed deterioration after SRS. 8.7% of our Cushing disease cases had some form of pituitary hypofunction after SRS. Regarding radiological response, complete resolution was seen in 11%, in 83% there was reduction of tumor size, and 6% showed stable, making 100% tumor control. There was no progression seen in our Cushing disease cases. Regarding biochemical response, 47% showed normalization of excess hormone, and and 47% are in a control or a reduced state, and as they are in their latency period. 6% of our treated cases are in uncontrolled hormonal status. Lastly, coming to refractory prolactinomas, total cases are 8. Majority were females, age range from 20 to 45 years. 87% had surgery before SRS, and 50% had some form of pituitary hyperfunction before SRS. 75% has a deranged perimetry before SRS, and after SRS, 80% perimetry improved and 20% showed stable status. 3 patients of our treated cases show some form of pituitary hyperfunction. Regarding radiological response, all 100% showed reduction of the tumor size. And regarding biochemical response, 43% showed normalization of excess prolactin, and 57 are in a control or reduced level as they are in their latency period. Lastly, coming to post-SRS neurotoxicity, review of literature shows that neurotoxicity range between 0 to 15%, and our treated patients only develop 2.5% of neurotoxicity after SRS. Lastly, I will go through some of our treated case. On the left are the pre-SRS, and you clearly appreciate that tumor bulk, and on the left side are the post-SRS images. This is another case which we have treated. Left is a pre-SRS and the right are the post-SRS. Another pituitary macroadenoma which we treated. This is a case of pituitary giant cell tumor. Pituitary giant cell tumor was first highlighted in 1940 by Jefferson. He told that pituitary adenomas with more than 4 centimeters are called as giant cell pituitary adenomas. And this last slide is also of our treated case. On the left is the pre-SRS and the right is the post-SRS. To conclude my talk, we provide state-of-the-art free radiosurgery to our pituitary adenoma patients with control of tumor size, excess hormones, and toxicity comparable to any radiosurgical facility of the world. Lastly, my deep thanks to Father of the Nation for providing us a place called home. And my last slide is not a political post. Being an oncologist, I know what free cancer treatment means to our population. And there is no words to thank Imran Khan. For providing state-of-the-art comprehensive Shaukat Khanum Lahore and Shaukat Khanum Peshawar. And inshallah, very soon, we will be blessed with Shaukat Khanum Karachi. This is the largest cancer hospital in Pakistan. Thank you very much. Any questions, please? मेरा ख्याल है being a radiation oncologist इस endocrinology seminar में मेरा कोई रोल इतना ज़्यादा फिट होता लगता नहीं है, इस वजह से questioning इतनी है नहीं.
Sir, I have a question. Do you engage every patient that qualifies the criteria for this SRS?
Sorry, repeat again.
I mean, does your hospital engage every patient with pituitary adenoma who qualifies the need for SRS? Because we have so many poor patients and we will be sending a bulk of patients from onwards.
We treat without discrimination, whether he can afford, from which sect he belongs, as long as he fulfills the criteria. We basically offer free treatment. There is no greed for money from our side. We try to follow the guidelines, okay? If there is severe compression of the optic chiasm and we cannot visualize the optic chiasm, or patient is sent first hand by any person who have seen our videos to treat this pituitary adenoma, we don't do that. We take the consent of the first. We take, if it is a non-functional pituitary adenoma, we take the consent of the neurosurgeon. If it is a case of functional pituitary adenoma, we take the consent of an endocrinologist, and then we proceed.
Thank you, sir. Thank you.
Thank you, Dr. Kamran, for a very comprehensive and emotional talk, and congratulations to the work that you are doing at your center. My question is just regarding the protocol in your functional tumors. For example, like in acromegaly. Like now you have quite a good experience of 160 patients, and the hormonal control is unlikely to achieve before 2 years. So should we now, if we are like holding the medications, for example, someone is taking the medications for 2 years every 6, so 2 months every 6 months, then maybe 1/3 of the year the patient is not getting the medical treatment. So now is this the time that you should revise that protocol? Maybe do not hold the medication for first year till you have the so the medications would hormonal treatment is not interrupted.
You're absolutely right. But basically, the ball is in your court, being an endocrinologist, and you people are going to decide. If you are giving some anti-secretory medications and patient is not responding and you have to increase the dose, then there is no, it's not justified to stop medication at 6 months. So it basically depends in your judgment when to stop it and when to see the response of radiosurgery.
Thank you very much, Dr. Kamran, for that presentation. I'm a witness to the evolution of the CyberKnife project in JPMC, and this was not a government-driven project. It is a testament to the philanthropy of the citizens of Karachi mainly, and others as well, that we managed to install, and the great effort of Professor Tariq Mahmood and his collaborators and the Patient Saeed Foundation, which continues to run it. And like Dr. Kamran said, whether or not you have the money doesn't matter. People, even people who pay for their treatment, they do so after the treatment has been completed. And they don't pay for the treatment. They pay whatever they can. Pay for themselves, pay for 2 other patients, whatever. And it's running very, very successfully. And then I have been interacting with Dr. Kamran as an endocrinologist with various pituitary tumors that we all in Karachi treat. And the pituitary MDT, which we have every month, where Dr. Kamran has his input. So all treatments are very meticulously considered and planned and executed. So this project is a testament to what people can do as individuals when they band together, because it didn't come from the government. Thank you very much, and thank you, Dr. Kamran.
You're welcome.
I need your last slide.
Sir, I have a question. Sir, we are very grateful for the service you are providing, because we send patients from Rawalpindi and all over Pakistan. I have one question which many patients and youngsters ask. Is there role of any retreatment with SRS in patients who do not respond after many years of treatment?
Basically, it's a gray area. The dose to the optic chiasm, we know that there is a cutoff dose to the optic chiasm. And if we treat a patient upfront with radiosurgery or conventional radiation, that cutoff is reached. So to go beyond that level definitely leads to optic pathway toxicity that may end into blindness. So my belief is that it is a benign tumor, it's not a malignant one. So why compromise optic pathway for a benign tumor? If God forbid it is a malignant tumor, then it is justified to save the patient or to save the optic apparatus. And I tell you, almost 100% of patients opt for their lives. If we treat a patient and the optic apparatus receives higher dose of radiation, we always call the patient and ask their opinion. For benign patient, it's not justified. But for malignant patient, it is justified just to save the patient's life.
Right.
Assalamu alaikum. Thank you, Dr. Kamran, and count me as well among the one who impressed from your lecture. When we were studying for the fellowship, we studied the radiotherapy as the last option. And among many disadvantages, it was stated that it is the treatment which is not repeated. It is once in life. This was my comment, but my question is that in Cushing disease, you said age from 8 years to 70 years, right? And we have studied that the children, they respond well to the radiotherapy. So should it be the first option in Cushing disease in children to refer them for SRS? Thank you.
Surgery is a gold standard. You cannot, it is not justified to omit that. And we cannot tell about future, what future lies for the patient. With surgery, if it is in a microadenoma, then it justifies that surgery should be done, as patient will immediately achieve a complete remission. But with radiosurgery, we cannot predict the time frame in which the patient will achieve the hormone remission. It may be 1 year or it may go up to 5 years. So why to expose a patient to the high dose of steroids? So it's justified to adhere to the principle that surgery is a gold standard. It should be done first. On the first option should be surgery, and if it fails to control excess hormone, then surgery should be the second option.
Thank you, Dr. Kamran, for such a comprehensive talk. Now I would request Dr. Shahid to present the appreciation certificate to Dr. Kamran.